Welcome to our presentation entitled Providing Practical Pediatric Practice Points for Pharmacists. Hi, I'm Peter Kreckel. I'm an adjunct assistant professor of pharmacology at St. Francis University in Loretto, Pennsylvania. There I teach all the pharmacology to the physician assistant program. One of the many discussions that we have with the students is the use of the medications we are most commonly associated with for pediatric patients. So let's talk about our goals and objectives for our lecture. We are going to list specific pharmacological and non-pharmacological interventions for common pediatric ailments. We're going to demonstrate the pharmacist's role in providing accurate pediatric dosage calculations, and we're going to review recommendations for the use of over-the-counter devices and medications for certain pediatric diseases. Let's first talk about the use of accurate measuring devices. Previous studies have found that teaspoons are commonly used to administer liquid medications to children. This comes as no surprise to us pharmacists, and we're well aware of the fact that household teaspoonfuls may range anywhere from 1.5 milliliters to 9 milliliters, which can potentially lead to dosing errors. In this study, it was found that oral syringes were more accurate than dosing cups or spoons. However, a large proportion of study participants were unable to measure an accurate dose with either device. We community pharmacists need to educate our caregivers on the selection and proper use of measuring devices so that we can improve accuracy for those medications that have to be administered at home. One of the common questions that we'll have is amoxicillin dosing for pre-medication for dental procedures. For amoxicillin dosing for a kid needing to go to the dentist for that prophylaxis before a procedure, the maximum dose is 2 grams, and 2 grams is the adult dose, so always keep in mind that a kid is never bigger than an adult. Seems obvious, but on a lot of test questions, my students will come up with 45 milliliters. So the truth is we always want to go with 2 grams maximum for the amoxicillin dose. A child's dose is 50 milligrams per kilogram 1 hour before the procedure. Should a child be allergic to penicillin, other oral medications we can use are clindamycin, which we know that has a very nasty taste, that liquid does, cephalexin or Keflex, azithromycin can be given 1 hour before the procedure, and clarithromycin as well, making sure with that clarithromycin that also has a nasty taste, and make sure the child takes that with food to minimize that GI upset. I have also all the milligrams per kilograms listed on this slide as well for you to download. Nice reference to have. Frequently dentists will call my store and say that a child is allergic to amoxicillin and what can they use instead. I'm going to teach a shortcut today on dosing for amoxicillin dental prophylaxis. When we use amoxicillin suspension, most commonly we use the 250 milligram per 5 cc. And I was once told, don't think of it as 250 per 5, think of it as 50 per milliliter. Since the dose is 50 milligrams per kilogram, as we said in the previous slide for dental prophylaxis, if we get out our 8th and 9th grade algebra books, we can cancel out the milligrams on each side of the equation, and for every kilogram the kid weighs, he gets 1 milliliter of amoxicillin, 250 per 5 cc's. That only works with the 250 for 5 strength, and it only works for dental prophylaxis, as we'll see later on. So let's say Johnny weighs 44 pounds. He needs his dental prophylaxis. We calculate his weight to be 20 kilograms. He gets 20 milliliters. And remember, the maximum dose is 40 mils or 2 grams, which is the adult dose, keeping in mind no kid is ever bigger than an adult. Well, who needs this dental prophylaxis? What we were trained with, and I graduated from pharmacy school over 30 years ago, was that whole laundry list of any kind of cardiac complications a child must have prophylaxis for. That all changed in May of 2007. So the patients that are at the greatest danger of bad outcomes from infectious endocarditis and for whom preventative antibiotics like amoxicillin before dental procedure are worth a risk are those kids with artificial heart valves. This is also true for adults, by the way. kids with artificial heart valves, a history of having infective endocarditis, certain specific serious congenital heart conditions, and I have the whole laundry list there for you, or any cardiac transplant which develops a problem in a heart valve. So basically any serious cardiac surgery, anytime we have a heart valve that is affected, then they'll probably be needing the dental prophylaxis. What does come as a surprise to us is who doesn't need dental prophylaxis. As of May 2007, the following patients no longer need infective endocarditis prophylaxis: those with mitral valve prolapse, those with rheumatic heart disease, those with bicuspid valve disease, calcified aortic stenosis, congenital heart conditions, right ventricular septal defect, atrial septal defect, and hypertrophic cardiomyopathy. And some of those are rather common conditions, but since May 2007, it is no longer necessary to prophylax these kids with the amoxicillin or those other antibiotics before doing those dental procedures. We did such a great job as pharmacists, as did our dentists and as did our cardiologists, that we put the fear of God into so many of these people that they're going to take their prophylaxis probably forever. And most dentists say if they've been on it for 30 or 40 years, why change it now? But this list on this slide will tell us that as of May 2007, it's no longer required. One of the most common ailments that we see is acute otitis media. The child is sick and the parents are sleep deprived. They can be a little bit grumpy as well. So let's go over the dosing as well as the treatment of acute otitis media. First of all, we have to remember that watchful waiting is the first route to go. Most kids really don't need antibiotic therapy for acute otitis media. It's been said that it's probably 75% of all the kids that get prescriptions really don't need them. So the first line is going to be watchful waiting, using ibuprofen, using acetaminophen, and I'll cover those dosages later in the lecture for you. So the first line for initial empiric therapy is amoxicillin HD, which is high dose, which is 90 milligrams per kilogram, and this is for your high-risk patients. If this patient, however, has had any antibiotic therapy in the last 30 days for whatever reason, we can use amoxicillin HD, Amoxicillin-clavulanate HD, Augmentin HD, or cefuroxime, cefdinir, cefpodoxime, or cefprozil. If they have had failure after 3 days of antibiotic therapy, then we need to switch them up to the Augmentin or the Amoxicillin-clavulanate HD, or cefprozil, cefpodoxime, cefuroxime, or ceftriaxone IM. If they've had antibiotics the past 30 days, then ceftriaxone, or clindamycin, or tympanocentesis, which of course we're not going to be doing in the drugstore. Failure at days 10 through 28, the same as above, just use a different regimen. And if they've had antibiotics in the past 30 days, again, amoxicillin-clavulanate, cefuroxime, ceftriaxone IM for 3 doses, and again, tympanocentesis. Let's talk about amoxicillin dosing for otitis media. Amoxicillin HD or high dose is considered to be first-line therapy for otitis media. Amoxil HD is defined as 90 milligrams per kilogram per day in 2 or 3 divided doses, either every 8 or every 12 hours. The package insert, when you pull it for amoxicillin, is still recommending 20 to 40 milligrams per kilogram for amoxicillin for pediatric dose. That is no longer recommended, and for about the past 7 or 8 years, only Amoxil HD has been considered as first-line therapy. Amoxicillin with clavulanate high dose is a treatment of choice for Amoxil HD failure. And the Amoxil UD or usual dose is, I call that with my students, Amoxil underdose. The usual dose is not recommended for use in otitis media. That's the 40 milligrams per kilo in 2 or 3 divided doses. Again, not recommended for otitis media treatment. Let's do a quick case study discussion about amoxicillin-clavulanate dosing. Here's our case study. Jenny's a 3-year-old, 37-pound female, and she's in need of amoxicillin-clavulanate for an ear infection that failed to respond on amoxicillin HD 90 milligrams per kilo per day therapy. So let's calculate her dose. 37 pounds divided by 2.2 pounds per kilogram will give us 18.5 kilograms. 17 kilograms times 90 milligrams per kilogram per day, just to approximate to make this easy, will give us 1,500 milligrams per day. What amoxicillin-clavulanate product would we give? Would we give Augmentin 250 per 5, 400 per 5, or 600 per 5? One of my practicing physician assistants that graduated in my first class sent me an email about 2 years ago and said, Mr. Kreckel, would you please go over amoxicillin-clavulanate dosing with your students? I know you covered, but I need you to reinforce how they should properly be prescribing it at 90 milligrams per kilo. Your students aren't so bad, but sometimes it's the medical school students and the ER physicians really butcher this dose. So here's our rule. When you're using Augmentin or amoxicillin with clavulanate in the high dose, and you should for any otitis media, 90 milligrams per kilo, you should always use the Augmentin ES 600 milligram per teaspoonful. And the reason that is on this slide is we can see with the amount of amoxicillin that we need, that 1,500 milligrams of amoxicillin, how much clavulanate exposure is the big concern. So if we're using Augmentin 250 per 5 like we would use Amoxil 250 per 5, to get the 1,500 milligrams of amoxicillin, you're going to need 6 teaspoonfuls, or expose the kid to 375 milligrams of clavulanate. However, when we see the part of the slide that I have done in red, we need 2.5 teaspoonfuls of the Augmentin ES, and we're going to expose the child to only 107 milligrams of clavulanate. So we have to be very, very cautious when we're dealing with our emergency room physicians and those less than seasoned pediatricians when they're prescribing the Augmentin doses. The clavulanate, as we all remember, is what ties up the beta-lactamase that some of the bacteria produce. The clavulanate also causes the nasty taste, but most importantly, that horrible GI upset, the diarrhea, and the cramping that kids get. So to give that kid the proper dose of Augmentin, we need to make sure we're using the 600 milligrams, the ES Augmentin, to minimize that clavulanate exposure. Otherwise, if we use some of the other products, the suspensions, we will expose that child to 2 to almost 3.5 times as much clavulanate than if we just use the Augmentin ES. As you can see from the chart, for a child getting amoxicillin 1,500 milligrams, they'll get 107 milligrams of clavulanate, and the prescriber then should always be using that Augmentin ES 600. Also, when you're prescribing the Augmentin HD for otitis media, it's critical to use the Augmentin to decrease the clavulanate exposure, as we said, for the GI upset and diarrhea. And also it's important for us as pharmacists to always recommend a protectant paste for diaper dermatitis. I tell my patients' parents to make sure that they're covering that little butt with any kind of a protective paste. Pick one you like. Diaperine, any of the A&D ointments, virtually any kind of a protectant paste, even good old Vaseline will work, just to make sure that when the child does get the diarrhea, and it's a sure thing with Augmentin that they're going to get the diarrhea, that the little backside is indeed protected. So it's a chance for us as pharmacists to intervene and to make sure that the little baby is taken care of, not only with accurate dosing, as we learned earlier on today, accurate dosing with an oral syringe. We want to make sure that the side effects that are inevitable to come are going to be taken care of. As I said earlier on, for the otitis media discussion, watchful waiting is what is recommended first line. Let's talk about the management of pain, be it from otitis media or from a cold or any other types of fever or pain. The analgesics that we'll discuss for management of pain for otitis media is acetaminophen or Tylenol, and we'll use 10 to 15 milligrams per kilogram every 4 hours for a maximum of 5 doses every 24 hours. So most of the time we get the weight in pounds. Most parents will know what their kids weigh in pounds. Not all, but most parents will know that. Some pediatricians will say, I'll just use 5 milligrams per pound, it's faster. But the recommended dose is 10 to 15 milligrams per kilogram for Tylenol. For ibuprofen, Motrin, or Advil, we can use 4 to 10 milligrams per kilogram every 6 to 8 hours. I'll generally use 5 to 10 myself. And a maximum of 40 milligrams per kilogram per day is your top dose. And then we also have the Arlgan otic solution, the old formula, still available as a generic, the antipyrine and benzocaine, and you fill the ear canal with the solution every 1 to 2 hours as needed. And every time I recommend any type of an eardrop, I remind the patients to warm it up in their hand or just stick it in their pocket for a little bit of time to warm up the drops. Cold drops in any patient's ear, including adults, will make them dizzy. Once I point this out to you as far as the treatment of diaper dermatitis, you'll see that a lot of pediatricians are not doing this right, and it might be a good opportunity for us to remind them of what is recommended for diaper dermatitis. 2/3 of all infants are going to experience diaper rash. Disposable diapers have greatly decreased the incidence. They have much lesser incidence of diaper rash because it pulls out the moisture and keeps it away from the skin. Breastfed babies have less diaper dermatitis than bottle-fed babies do. And the causes of diaper dermatitis, again, are moisture, bacteria, alkaline pH, that mechanical disruption of the area. Sometimes those little elastic leggins will cause some rubbing and irritation, as well as the digestive enzymes and bile salts. This is why a lot of pediatricians will recommend using things like Aquaphor with cholestyramine paste, because the cholestyramine, an old cholesterol drug, ties up those bile salts. The thinner skin in infants and elderly, let's not forget our elderly patients in this discussion, predispose them to this diaper dermatitis. Rarely are either patient groups allergic to the diaper materials or the dyes or what's in them. Most of the time it is diaper dermatitis indeed. The bacteria may include the Streptococci, the Streptococci, Staph, Bacteroides, and E. coli. However, 80% of the cases where symptoms have been present for 3 days, where it's really a problem, we're going to see Candida albicans. Good old yeast is going to be growing there. Untreated overgrowth of Candida albicans leads to ulceration, maceration, and can also lead to urinary tract infections. Let's talk about the non-pharmacologic management of diaper dermatitis. First, what we need to do is frequently change the diaper, and that's obvious to get that exposure minimized to the feces and to the wetness. So ideally, too, if the patients are adventurous and they have a linoleum floor in their kitchen, they can expose the baby's butt to dry air. Not recommended on your new oriental rugs. We can clean the area with water and avoid rubbing the area. What I recommend is using one of those squirt bottles, a clean squirt bottle with warm water in it. Spray it on the butt, pat it, and let it air dry. Make sure we're not using those alcohol-based wipes for the babies. We can also use protectants, which are first-line therapy, especially when we're treating a patient that's going to be exposing themselves to augmentin therapy for otitis media. So the first-line therapy is a protectant, and we're going to always anticipate that anytime we dispense augmentin or any other kinds of antibiotics. What the protectants are going to do is provide that physical barrier to protect the skin against the irritants, those bile salts, as well as moisture. It'll also provide lubrication to reduce skin-to-diaper friction as well. So those protectants, as I said earlier on, can include A and D ointment, which is petrolatum and lanolin, Desitin, diaper rash, zinc oxide, cod liver oil, petrolatum, lanolin, and talc. The Desitin creamy ointment is a little easier to apply. It doesn't seem to drag on the skin so much. That contains the zinc oxide, dimethicone, petrolatum, and mineral oil. We do not recommend using talc or cornstarch because of the potential for inhalation. Keep in mind what talc is. Talc is actually a rock. It's a mineral that's ground up very fine, and although it does absorb moisture, it can get into the lungs, and especially if you're dusting it on the baby's backside and frequently they're crying, they could very well inhale or insufflate some talc. Same problem with cornstarch as well. They can inhale that. And think about cornstarch. It's starch. It's a couple sugars linked together. Oh gosh, not more organic chemistry. That's about my level of expertise on that subject. But anyhow, our cornstarch, being basically a sugar, sometimes just feeds the bacteria. So I don't recommend talc or cornstarch for diaper rash. And our FDA cautions that Peruvian balsam may cause skin sensitivities. The infamous butt paste. There's lots of different formulas for butt paste, but some kids are allergic to that Peruvian balsam, so that might not be an ideal choice in some of your patients. Let's talk about the pharmacologic management of diaper dermatitis. Antifungal agents are very effective in treating diaper rash, but use them only when Candida albicans is suspected. And Candida albicans infections are characterized by those beefy red plaques, those kind of thickened red plaques with scales. They'll also have some satellite papules, pustules, and they're just on the top of the skin. It's not usually a real deep lesion. We can use miconazole, clotrimazole, which are over the counter, or you can use nystatin, which is prescription only. Keep in mind too with nystatin, always a good question for your pharm students that you might be precepting. Nystatin is only effective on Candida. It has no effect on any of the dermatophytes, so you can't use nystatin for jock itch. You can't really use it for athlete's foot. You can't use it for treatment of ringworm. Nystatin is really only indicated for and is only effective for Candida albicans infections. Orally, we can treat diaper rash. We can use fluconazole or diflucan liquid at a dose of 6 milligrams per kilogram once a day. We can also use corticosteroids, but only hydrocortisone. Over the counter is all we should be using, because we'll learn that it is not recommended to use stronger corticosteroids. You should avoid all RX corticosteroids on the baby's butt. They can be used for up to 2 weeks maximum, your over-the-counter hydrocortisone for maximum. Clotrimazole and betamethasone, the infamous Lotrasone cream, a recent survey of pediatricians found that 25% of the pediatricians are using clotrimazole and betamethasone. And the next time you pull that generic Lotrasone off of your shelf, take a look at the package warning, and it says right on the package that it is not to be used for diaper dermatitis. The only corticosteroid that we can recommend for use on a baby's butt is hydrocortisone, and no more than 1% over the counter. Let's talk about vitamin supplementation for newborns. The American Academy of Pediatrics recommends vitamin D 400 international units per day from a few days after birth through adolescence. The maximum pediatric dose recommended is 1,000 international units for age 1 or less. Milk and infant formula contain about 100 international units of vitamin D per 8 ounces. You must drink 1 quart a day to achieve 400 international units. There are very few dietary sources of vitamin D that's going to give you the recommended amount. Yes, we can extrapolate this slide to our adults. So when an adult tells you that they don't need vitamin D supplementation over the counter because they drink milk, they need to drink at least 5 quarts of milk a day to get to that 2,000 international units of vitamin D. Everyone needs supplements, including breastfed babies. Some of those vitamin D supplements are just D-bisol, and there's also some generics available as well, and we can recommend those for our vitamin supplementation for our newborns. Where I live here in Tyrone, Pennsylvania, in central Pennsylvania, our water is fluoridated. And when I practiced in Tyrone for a number of years, I didn't dispense much fluoride. It was the only time we dispensed fluoride is when we were dispensing it to people that lived out in the country that had well water. Now that I live in Altoona, in Altoona, Pennsylvania, where I practice, they don't have fluoride supplementation there in their water, so we use a whole lot of fluoride. We buy our fluoride 1.1 milligrams and our 2.2s in bottles of 1,000, and we'll use it rather quickly. So the reason that we supplement with fluoride is anti-karyogenic because it replaces the hydroxyl ion in the hydroxyapatite within that fluoride ion form, fluoroapatite, on the outer surface of the enamel. It hardens the enamel. What I liken this to for my patients is I tell them that the enamel, if you would really blow up a picture of it, it kind of looks like a chain link fence. The fluoride actually welds the chain link fence together to make it a whole lot harder. So the fluoroapatite hardens the enamel and makes it more acid resistant. Fluoride also has demonstrated some antibacterial activity. Fluoride obviously is most beneficial from birth to age 12 because uninterrupted permanent teeth are mineralizing at the time. When a person receives fluoride supplementation, whether we give it to them or not depends on the concentration of the drinking water. Altoona, PA, no fluoride in the water. Tyrone, PA, lots of fluoride in the water, so we're going to supplement in Altoona, but not necessarily Tyrone. The caveat to that is some people are drinking bottled water in their homes. So I have on this slide the fluoride dosing based on the water supply, and you can call your local water department and get these numbers. In Tyrone, they mail us a letter every year telling us what the current ppm of fluoride is. If you have a water concentration of fluoride 0.6 ppm or greater, no one gets fluoride supplementation. That's easy. And that's where we are in Tyrone. If the water concentration of fluoride is 0.3 to 0.6, from 6 months to 3 years, they get no fluoride supplementation. 3 to 6 years, they'll get 0.25 milligrams per day. And if the child is between 6 and 16, they get a half a milligram a day. If there's no fluoride in the water or less than 0.3 parts per million of fluoride, 6 months to 3 years, those kids get 0.25 milligrams a day. 3 to 6 years, they get a half a milligram a day. And age 6 to 16, they get a full milligram a day. And believe me, I counsel a lot more patients in Altoona about fluoride supplements. First things we want to tell our patients about fluoride supplements: keep them out of the reach of the children. Make sure they're kept in a child-resistant bottle. Fluoride supplements are prescription only, and they must be chewed. The kids should not try to swallow those tablets whole. They do have a flavor to them, and they're flavored pretty well, so it's advisable to keep them out of their hands to minimize any risk of poisoning. The chewable tablets, as we know, are available as sodium fluoride, 0.25 milligram chewable, a half milligram chewable, and 1 milligram chewable, and the solution that's 0.5 milligrams per mil. Milk and other dairy products may decrease absorption, so most of the time we tell patients to take it at night after the child brushes their teeth. Sodium fluoride 2.2 milligrams equals 1 milligram of active fluoride ion. 1.1 milligram is equal to 1/2 a milligram of active fluoride ion, and depending on your computer software, you can create a lot of confusion for your patients. So ideally, if you can modify it that says 2.2 milligram sodium fluoride, parentheses 1 milligram of fluoride, is probably the easiest way to do it. And I always go out on a new start and tell these patients that their doctor wrote for 1 milligram, the prescription reads 2.2, and tried to explain the basic chemistry behind it. Also counseling them to probably give it to the kid at bedtime after they've brushed their teeth and flossed, and also to chew it before swallowing. Topical fluoride. Fluoride is found in a wide variety of toothpastes and dental rinses. All of the topical therapies have some anti-karyogenic potential, but it's not nearly as potent as the oral fluoride. We're seeing more and more kids being diagnosed with asthma, being diagnosed at a much younger age, and we need to discuss the asthma management spacers. Spacer devices, and we're all familiar with them. There's a whole bunch of them that are available. Anything from they look like a small tube of toilet paper roll all the way up to the big gargantuan devices that have the paper liners in them. The spacer devices with an inhaler will help to deliver the medication to the lungs and dramatically decrease the amount of medication that gets deposited in the back of the mouth and on the tongue. Those blasting inhalers that, especially those old CFC ones, had a lot of blast to them, and it would just kind of hit the back of the mouth or the tongue. A spacer kind of captures that medication into a chamber, and it's then released from the inhaler, and then the kid gradually inhales it slowly, deep breathing once or twice, so it kind of catches that puff, and then the kid can gently inhale it and get a much better delivery onto the lung tissue. A spacer is recommended for any child who has difficulty squeezing the canister and inhaling at the right time, and especially those little ones under 6 years of age. Spacers are recommended for all children who are using inhaled glucocorticoids. So if the child is on any kind of those inhaled ones like Qvar or the Flovent in the pressurized container, it is recommended that they use a spacer along with those. Larger size spacers, 100 to 700 mil spacers, appear to be more effective than the smaller ones, but a smaller spacer is infinitely better than no spacer at all. And the proper technique and frequent cleaning are important when you're using the spacer. Kids should be, and parents should be, washing out those plastic inhaler canister sleeves anyhow, and they should also be as meticulous cleaning the spacer. Let's talk about treatment of croup. And we're seeing lots and lots more kids with different types of croup. Types of croup can be viral croup. They can also have a spasmodic croup, which is generally caused by acid reflux from the stomach or by an allergy. But the presentation is the same. Croup is usually viral, and antibiotics are not effective. Inhaling steam or cold air does seem to help depending on the child, and a lot of times what they'll say is have mom go into the bathroom, turn on the shower, hot steamy water, and just sit and hold the child and let them inhale the steam maybe on the other side of the bathroom. Inhaling steam does seem to benefit a whole lot. A lot of our pediatricians are using dexamethasone, which we know is probably one of the more potent, and it is definitely the longest acting of the corticosteroids, which corticosteroid is a word that we do not use at Broad Avenue Pharmacy. I have taken the word corticosteroid out of my vocabulary. They're called anti-inflammatories now. The word steroid just makes patients cringe. You get lots of questions, so dexamethasone is a very potent anti-inflammatory, and it's for the benefit of mild, moderate, and severe croup. It decreases that inflammation and it relieves the symptoms. It stops that barking cough, that stridor as we call it, the difficulty in breathing or wheezing. The anti-inflammatories reduce the need for hospitalization and intubation. And when we think about it, those virulent germs are in the hospital. We should be avoiding them anyhow. The dose for the treatment of croup is a big one. It's 0.6 milligrams per kilogram of dexamethasone IM or orally. So it's not uncommon for us to see, maybe 10 milliliters of dexamethasone. So we are seeing some pretty hefty doses of dexamethasone being given, and that's fine because the recommended dose for the treatment of croup is 0.6 milligrams per kilo. Lots of kids come to the drugstore with conjunctivitis or pink eye. The parents see that reddening, those matted eyelashes, and they bring the kid down to the pharmacy. Can't you give them something, doc? And the answer is always, to me, warm compresses. Most cases of conjunctivitis are viral. Even bacterial infections will resolve frequently without antibiotics. In our pediatric population, 50% of all conjunctivitis is viral, so there's nothing you're going to do to treat it, and the other are 50% bacterial, and antibiotics are generally not needed for those. But there's a little caveat we'll talk about. Recommended symptomatic treatments such as cold or warm compresses or ocular lubricants and decongestants might help. Emphasize frequent hand washing. Every time that kid touches their nose or their eyes, they should be washing their hands. Anytime mom handles the child, she should be washing her hands as well to decrease the spreading of infection. I always tell my patients if they have that community bathroom downstairs or upstairs that more than one person uses, they should take out all of the hand towels and replace them with paper towels just to decrease that spreading. Save the antibiotics for patients who don't improve in 5 to 7 days or earlier if daycares require it. And that's where we see a lot of antibiotic eye drops being used, is in those little daycare kids, because the teachers will not let them back in class if they're not treated for the pink eye with an antibiotic for 1 day before returning to class. So the patient is contagious until antibiotics have been on board for at least 24 to 48 hours. The viral infections are usually contagious until the eye is completely clear. So it is not uncommon for us to dispense those oral antibiotic drops, the quinolones or the aminoglycosides, to a patient that has this pink eye just to get them back in daycare. We always want to avoid the sulfacetamide, any of the sulfa drugs on the eye, knowing that the eye is one of our most sensitive mucous membranes. The sulfa is the most allergenic of the antibiotics. So the treatment of pink eye, we're going to want to avoid those sulfa-containing drops because of that hypersensitivity potential. Aminoglycosides we can use, tobramycin and gentamicin. The fluoroquinolones we can use are ciprofloxacin and ofloxacin. Those first and second generation ones are cheap enough and they do the job quite nicely. The dose is usually 1 drop every 2 hours for the first 2 days, then 4 times a day for up to 7 days. Use it till the eye is completely clear. A lot of pediatricians will say till the eye is clear plus another full day. There's another topical drop that works very well and is probably ideal for kids going to school and daycare, and that is the azithromycin eye drops, or the Azicite. Unfortunately, it costs about $70 a bottle. The drop goes into the eye every 12 hours for 2 days, then just once a day for the next 5 days. So it's kind of like a Z-Pack for the eyes. The first couple days we're going to put 1 drop in the affected eye every 12 hours and then just once a day thereafter. You want to refrigerate it before dispensing, but leave it at room temperature after dispensing. It kind of gets thick and gooey, so that'll kind of thin it out a little bit if it's left at room temperature for the course of therapy. I had one of the local pediatric clinics review this PowerPoint presentation before I would present it to you. And one of the things that the pediatrician wanted me to emphasize is thermometers. The pediatrician and her nurse said that it's definitely the calls that they get the most from new moms are thermometers, as far as accuracy, as far as when to bring the child into the office for a fever. So we're going to spend some time discussing thermometers. Used to be easy in the old days when you had rectal and oral, but we have a whole bunch of them now. And as far as accuracy goes, rectal temperature with a rectal thermometer is still the most accurate, followed then by the temporal there on the forehead, oral, ear, and then axillary, or the armpits, is the least accurate. There are pacifier thermometers. They have to be left in the mouth for about 6 minutes. Ear thermometers are relatively accurate, but the problem that causes their inaccuracy is if there's infection in the ear, and cerumen or earwax can affect the accuracy. We're going to always recommend using rectal thermometers if the infant is under 3 months of age. We can use oral under the tongue. The mouth has to be closed for 30 seconds, and sometimes that can be a challenge with a child. The rectal temperature is equal to the temporal temperature, which is equal to the ear temperature. The oral temperature is 1/2 to 1 degree lower, and axillary is 1 to 1.5 degrees lower. So when we're going to consult our pediatrician, we're going to tell mom to give the pediatrician a call any fever in a child under 3 months of age. If the fever is over 24 hours in a child under 2 years of age, If there's any vomiting, diarrhea, sore throat, ear pain, we're going to want to consult the clinician. And if we have an infant younger than 3 months of age with a temperature of 100.4 degrees or 38 degrees Celsius, or an older child with a fever over 104 or 40 degrees Celsius, we are going to need to consult the pediatrician. Other things we can tell mom as well to look at: if the child continues to fuss after a couple hours of comforting, if the child is feeding poorly, if the child seems a little bit droopy or less responsive, and if the child shows no improvement in any kind of cold symptoms after a week to 10 days or have a mild cough in 2 weeks, we're going to want to consult the pediatrician. So if the child's acting lethargic and kind of droopy, that's also an indication as well to give the doctor a call. Let's talk about the treatment of fever. For acetaminophen or Tylenol, we can use the same doses we did for the treatment of pain, which is 10 to 15 milligrams per kilogram every 4 to 6 hours, maximum of 5 doses every 24 hours. For the ibuprofen, 4 to 10 milligrams per kilogram every 6 to 8 hours, and a maximum of 40 milligrams per kilogram per day. The acetaminophen or Tylenol is available as a liquid over the counter. You still might have the concentrate on your shelf. It's not really going to be available much longer, if at all. So the Tylenol is 160 milligrams per teaspoonful, and that's what we're recommending where I work, just to decrease any chance of dosage errors. There's also those chewable tablets of 80, 160, 325, 500, and 650 milligram tablets for the older, larger kids. Motrin and Advil are available as 40 milligrams per mil. That's that infant concentrate, easier to measure. And there's also the bottle with the teaspoon that we use, 100 milligrams per milliliter. There's also tablets available, chewable 50 milligram and 100 milligram chew tabs, and then the swallowable oral tablets as Motrin, Advil, and the over-the-counter ibuprofen generics as well. Another common malady that we need to treat in our babies is thrush, or a Candida albicans infection of the mouth. And what that looks kind of like cottage cheese left over in the mouth is what I liken it to. They're creamy white plaques that are inside the mouth. And it's rather common those first few weeks of life. It's less common in older kids, and it's possible if antibiotic therapy has been used, or any kind of inhaled corticosteroid therapy or anti-inflammatory therapy. Anytime that we use anti-inflammatory therapy in the mouth, we always want to tell those patients to rinse and spit, and we're quite comfortable doing that. And what can happen is this thrush can develop if they don't. We need to eradicate that Candida albicans from the pacifiers, bottles, nipples, chew toys, or also from mom's breasts. The treatment for mom is you can apply either miconazole or clotrimazole cream directly after feeding, and then it can be wiped off right before the next feeding. So if she's feeding baby every 4 hours, chances are pretty good she'll get a good 3.5 to 4 hours of treatment before she wipes it off. The treatment of thrush, we can use nystatin suspension, which is available as 100,000 international units, 4 to 6 times a day after feeding. Remember, it's that contact with the lesions is what cures the thrush. The child can swallow it, but once it's swallowed, there's no more effect to it. So we want to instill it into the buccal fold, the inside part of the cheeks, and if you can kind of squeeze the cheeks a little bit, try to increase that contact time of the nystatin to those lesions. That will greatly help the outcome. If you have an older child, say an asthmatic that's 8, 9 years old, you can use those clotrimazole troches. The Miselex troches is the brand name, and they can be used inside the mouth. They're usually dosed 5 times a day, and it's the same rules. Do it after the child eats, because it's that contact inside the mouth, and the kid shouldn't eat or drink for about a half an hour after using clotrimazole or nystatin therapy. Fluconazole can be given orally at 6 milligrams per kilogram per day, and that's especially useful if they try and fail on the nystatin therapy. Summertime brings Impetigo contagiosa, and a lot of kids wearing their shorts will see these Impetigo lesions on their body. Impetigo is really easy to diagnose. It develops rather quickly. It appears as a circular, honey-crusted lesion with ragged edges. I always just look at the border between the healthy skin and the lesion, and if it's real ragged, like white and ragged, that's going to indicate to me that it's probably Impetigo contagiosa. The causative agent is group A strep. Other hints, make sure we're clipping the kids' fingernails, because sharp fingernails will have the kids scratch open those lesions, and then once it's underneath their fingernails, it'll move around. It differs from bullous impetigo, which is usually caused by Staph aureus, both methicillin resistant as well as methicillin sensitive. That, when the lesion breaks, it's more like a varnish-like crust. It's a lot more shinier than the ragged-looking Impetigo contagiosa. Treatment of Impetigo includes Altobax, which is still only available as a brand name, and that's applied just twice a day for 5 days. Mupirocin, which is available generically in the ointment, brand name is Bactroban. That's applied 3 times a day for 7 to 12 days. So for mupirocin, you have to apply it more often and for a longer time period. We can also use the oral azithromycin, clarithromycin, and erythromycin. The treatment of the bullous impetigo, a little harder because we have the methicillin resistance can be a problem. If it's methicillin sensitive, we can use dicloxacillin, oxacillin. We can also use the macrolides and amoxicillin-clavulanate, and we can also use the mupirocin and the Altobax. If it's methicillin resistant MRSA, community acquired MRSA, then we're going to use the mupirocin or oral therapy with trimethsulfa or clindamycin. Minocycline and doxycycline can be used, but only if the teeth are fully erupted, because if we don't, we will see staining of the teeth. We have some of the counter treatments available for pinworms. It's caused by Enterobius formicularis, which is a 5 to 10 millimeter long worm. It's characterized by very intense anal pruritus, a lot of anal itching. The kids are scratching back there all the time, and the worms are in the stool, and the eggs also can be on the perianal skin. What a lot of docs will do is put some double-sided sticky tape like on a popsicle stick and just touch it lightly to the baby's butt, and you'll probably catch a worm or at least some eggs by doing that test. They'll take a tongue blade and do that. You need to emphasize personal hygiene. Make sure the kids' fingernails are clipped short, bathe frequently in the morning, and change clothes frequently. Hot, soapy water in the washer. They should be done virtually every day. The treatment of pinworms, it's rather easy, but it has to be done right. It's the reinfection seems to be the problem. We want to treat all household members at the same time to prevent reinfection. Drugs have no activity on eggs, so we need to take the dose, which will kill off the worms, but we need to retreat in about 2 weeks to kill those newly hatched eggs. Those newly hatched eggs become adults, and then they need to be killed off in about 2 weeks. The drugs we're going to use are parental pamoate, 11 milligrams per kilogram for a maximum of 1 gram, and that is available over the counter. We've seen shortages with mebendazole and Vermox. You might not be able to get a hold of that drug. Then we can use Albenza or albendazole as a single dose, much more expensive than the Vermox was, but the parental pamoate seems to still be effective for pinworm infections. I think every pharmacist, when September rolls around, starts thinking, 'tis the season for head lice. It just seems to travel like crazy in September and October through families as well as classrooms. So let's talk about the treatment of head lice. Permethrin 1%, the Nix cream rinse, is available for treatment of head lice over the counter, and it's still considered first-line therapy by Sanford Guide as well as most pediatricians. It remains on the hair shaft for about 14 days despite normal shampooing. So Nix cream rinse can be used prophylactically if it's an epidemic, and we're going to define an epidemic of head lice where over 25% of the population is affected. Whether it's your family, whether it's daycare, or whether it's a classroom, if more than 25% of the kids are sent home with head lice, we can treat the kids that don't have the head lice yet prophylactically with Nix Cream Rinse. It is 70 to 80% ovicidal, and it can be used on kids age 2 months and older. Nix Cream Rinse is the only one that goes down to 2 months of age. There's also a newer one called benzyl alcohol lotion, Ulesphia, and that costs about $150 per treatment. The mechanism of action, it does not have ovicidal activity because it suffocates the lice. It inhibits the lice from closing their respiratory spiracles, which allows the product to penetrate the lice, and it causes them to asphyxiate. You can use benzyl alcohol lotion on babies only down to 6 months of age. The environmental eradication of head lice, change the clothes daily. All household contacts should be inspected and treated if necessary. We should take all of the bed linens and clothes and wash them in the hottest water available and dry on the heated cycle of a dryer for at least 20 minutes. We want to wash all hairbrushes, combs, and toys in hot water at least 130 degrees for at least 10 minutes. Any of the stuffed animals, pillows, and articles that can't be laundered should be stuffed into a large trash bag, seal the bag, and hold on to it. Generally put it in a closet or down in the basement so the kid can't get to the toys, and let it alone for at least 2 weeks. As we know, lice can't live for more than about 7 to 10 days without a human host, so that's enough treatment for those things that we cannot launder. All household items such as carpets, chairs, and couches should be thoroughly vacuumed. OTC sprays such as the A200 and RNC spray have not been found to be any more effective than vacuuming. So get out the shop vac, get out the dust buster, and thoroughly vacuum those couches, chairs, and carpets. And it's really not necessary to use those insecticides like A200 or RNC spray. What about nausea, vomiting, and diarrhea? We get a lot of questions, and sometimes just fluid replacement is all that the child's going to need. Fluid replacement is essential for treatment of nausea, vomiting, and diarrhea. We want to avoid Pepto-Bismol and kaopectate. The new formulation of kaopectate contains bismuth subsalicylate, and as we know, subsalicylates, as all salicylates, should not be given to any child under age 18 with a viral infection, because of the increased chance for Reye's syndrome. So Pepto-Bismol should be avoided, as should kaopectate. And a lot of the older pediatricians are not aware yet that bismuth subsalicylate is what's in kaopectate. The Canadian formulation still has kaolin and pectin, but not the United States formulation. We need to avoid certain fluids while we're doing this rehydration. We want to avoid those hypertonic fruit juices and drinks, carbonated beverages, and caffeine-containing beverages. We want to avoid powdered gelatin mixes like Jell-O, which can make the diarrhea worse. And they don't have those necessary electrolytes. Even our hallowed Gatorade should be diluted with water because it still contains too much sugar as it's packaged for treatment of diarrhea. The ideal solution to use is Pedialyte. Pedialyte is an oral electrolyte replacement solution. We sell it in liters. There's lots of flavors. Most kids feel that grape is the best tasting flavor, but there's also fruit, plain, and bubble gum. We're seeing a lot more children affected with spitting up, with GERD, and over 50% of the babies will spit up frequently during their first 4 months of life. The irritable babies with regurgitation often will get that acid suppressive therapy. We're going to use a couple different drugs that are very effective in suppressing the acid formation or the acid release into the stomach. Fewer than 20% of these infants have abnormal gastric pH, however. Reflux is rarely serious. So we have kids that are called happy spitters. They feed well, they gain weight, and they'll grow out of it by 18 to 24 months. They're happy, they just spit up a lot. The worst is over after about 4 months of age, and ideally you want to give them smaller and more frequent feedings. Reflux or irritability can be due to milk allergy, constipation, colic. Smoke exposure can be a big problem as well. So we always want to refer these babies to the pediatrician if they're spitting up blood, if they have frequent diarrhea, if they refuse to feed, or they're not gaining weight. If GERD is suspected, suggest a 4 to 8 week trial of acid suppressive therapy. We'll see omeprazole, lansoprazole being used as the most studied PPIs. Let's go over some of those doses for the treatment of GERD. Ranitidine, Zantac liquid, is available as 5 to 10 milligrams per kilogram per day, and we'll give that 2 to 3 times a day in divided doses, no more than 300 milligrams per day. Famotidine or Pepcid, if the child's less than 3 months, we can use a half milligram per kilo once a day, and if the child's over 3 months of age, we can do a half milligram per kilo twice a day. Prevacid is approved for ages 1 through 11. We can go 15 milligrams daily up to 30 kilograms, and once the child's over 30 kilograms, we can go to 30 milligrams once a day. The FDA has Prilosec approved for children over 2 years of age, 1 milligram per kilo daily or twice a day. And the Prilosec, Prevacid, and Nexium are gelatin capsules with enteric-coated pellets. The capsules can be opened and mixed with orange juice or applesauce, and I know a lot of my compounding pharmacists out there are making liquid Prilosec for pediatric use. It can be kind of a bear to make that stuff because of all the fizzing and the bubbling, and it takes a good bit of time to make those PPIs in a liquid form for the babies. Constipation is always a concern as well. Dietary measures are what we want to always employ first. We want to increase fluids. We want to increase fruits and vegetables. Fruit juices with sorbitol, and sorbitol being a sugar alcohol, can cause diarrhea, as we know, such as prune juice, pear juice, and apple juice can all be given frequently to help with the constipation. Polyethylene glycol 3350 before going on other osmotic laxatives is recommended, and that dose is 0.7 to 1.5 grams per kilogram per day for kids over age 2. The maximum is 17 grams per day, the usual adult dose, and it may take about 1 to 3 days for it to work. Miralax is the brand over the counter. Glycerin suppositories will help if need be, if you have to have some fast relief for the babies. They work quickly in about 15 to 60 minutes. Docusate can help kids who have those hard, dry, hard to push out stools. Problem with Docusate is it does have that nasty, bitter, soapy taste, and it does take several days for it to work. Stimulants such as Senna or Bazakadil for rescue therapy can be used when other treatments fail, but they can cause a lot of abdominal pain and cramping. So ideally, we want to get the dietary measures in line first with those fresh fruits, vegetables, and those fruit juices as well. Cough and cold. Pharmacists like me remember back when we had the concentrated products of Dime Tap that the pediatricians could write for babies that were having cold symptoms. Currently, children's products are no longer labeled for kids under age 4 or age 6. We had too many ER visits due to cold medications, and because of that reduction in age that can take these cough and cold products, we see 50% less ER visits. OTC cough and cold products don't provide much benefit to young kids, and they cause a lot of adverse effects, and that's why we had so many ER visits. Ideally, we want to recommend drinking lots of fluids. Pushing fluids, nasal saline drops will help, and a bulb syringe to suck out that extra mucus, making sure that we're thoroughly cleaning out those nasal aspirators. Acetaminophen and ibuprofen for fever and discomfort. We gave you those doses earlier on in the presentation. Dispense an appropriate measuring device, as we said, and teach the patient's parents how to use those and how frequently to give them. Humidifiers. Humidifiers are definitely a controversial appliance to be recommending for pediatric use. Cool mist humidifiers for a child who has congestion or rhinorrhea, we have to keep in mind it may make allergies worse. If the kid does have allergies to dust mites and molds, if we're dumping more water into the air, we're going to see an increase in the amount of dust mites, and we're going to see an increase in the amount of molds, knowing that molds appreciate warm, dark, and moist. And by using a humidifier, especially if it's excessively, we're going to see an increase in mold growth. Dust mites and mold like those high humidity levels, so a humidifier increasing the humidity might actually make the allergies worse. In this situation, you actually want to keep humidity levels low, and an air conditioner or a dehumidifier can help keep those humidity levels low, 50% if possible. Our local allergist says he likes 30% relative humidity inside the house is best to decrease the dust mite growth but not make it too dry. Our local allergist said sell them a humidistat before you sell them a humidifier. Over-the-counter drugs for nursing moms. Let's remember some things that mom needs to take or mom can avoid while she's nursing the baby. Analgesics, the recommended is acetaminophen or ibuprofen, has the most safety data. Always avoid aspirin and salicylates because of Reye's syndrome. Antihistamines, loratadine or Claritin, and your first generation antihistamines can cause a good bit of drowsiness for the baby. So let's go with Claritin for the mom so she's not drowsy, because if we're using diphenhydramine and even chlortrimeton or chlorpheniramine can cause a bit of drowsiness for baby. The decongestant, pseudoephedrine, can possibly decrease milk production along with phenylephrine. Saline or other nasal sprays are probably going to be your first line therapy. Oral decongestants like Sudafed might cause some irritability because of the restlessness in the baby. For cough products, guaifenesin and dextromethorphan are probably safe, but they bring such a modest benefit you might just want to avoid them. They do contain a small amount of alcohol in the OTC cough elixirs, and that's not likely to be a problem. But again, it's risk versus benefits, and most of the time the benefits are minimal. Mom might just want to avoid those products. The gastrointestinal agents, most of the OTC laxatives, bulking agents, antacids, and GI stimulants are okay. And the H2RAs, the H2 receptor antagonists, such as Zantac, Tagamet, Anaxid, and Pepsid, are generally more studied and can be considered to be safer than the omeprazole and the other PPIs. Some physicians are not real fond of using the Tagamet because Tagamet, cimetidine, can cause blocking of testosterone synthesis.